20% risk of complete heart block after the procedure, which is a known complication for open aortic valve replacement anyway, but it's far less common with open heart. But in terms of core valve, it's looking at about 15% risk of complete heart block. And the reason is because there's a stent below the valve pushing onto the AV node, which is just underneath the aortic valve. And that's the reason why it's complete heart block. Sometimes you have some signs we'll know in the cath lab and we'll warn you in advance. But otherwise, in terms of rhythm, then we have to make sure that there is no complete heart block during the stay. And we'll be doing daily ECGs afterwards, right? Now, pericardial effusion and tamponade, again, if you remember that picture with the wire inside the ventricle, it's a very stiff wire. It has a soft tip, which is about 5 centimeters, but we bend that so that actually the tip at the apex is actually quite stiff. And sometimes that can perforate into the apex of the heart, and that can give you a pericardial effusion or tamponade. We'll be doing echoes afterwards, of course, but and of course if it's a major pericardial tamponade, we'll be tapping that inside the lab already. But something to look out for if you see, a massive increase in the JVP, low blood pressure, and the patient's not responding. We just have to make sure there's no tamponade. Congestive heart failure, sometimes that can happen. Rare, so of course there could be stroke. Aortic dissection, and then some of the other stuff like bleeding or DVT, that's far less common. So in terms of post-op day 0, as I say, the patient will be extubated on table. So the patient should arrive to the ICU awake, where the vascular closure should be secured. In the usual circumstances, not the patient in 2 weeks' time, you should have temporary pacing wires. Oftentimes we want to pace them a little faster than the natural rate. So we'll probably pace them at around 80. Hopefully we can go to atrial, so it'll be DDD 80. Hopefully it's just atrial pacing. Sometimes, if it's just, we don't pace atrially, we might pace ventricularly. But we would need to be testing the thresholds, making sure the site is okay, and then making sure, once in a while, making sure the patient is not complete heart block. There'll be a central line, and that we'll have to put on CVP monitoring. There'll be an A line radially, so we'll have arterial blood pressure, and then there'll be a Foley catheter, and the patient really can be managed in the HDU as well, because the patient's awake, it's not extubated. Okay, now these are the criteria. We should be aiming at a mean arterial blood pressure of at least 70 to 80. And that will give you good enough urine output. Now with these patients, the problem is because they've been aortic stenotic for such a long time, often at times when you relieve the aortic stenosis, they will have a very low preload. So they'll be very dehydrated in a way. So we'll be filling them up with lots and lots of fluid. And we'll be aiming at a CVP of about 10 to 15. I would rather edge on the 15 side. Now, in some patients, for example, very small elderly lady, the heart will be very thick. There will be a lot of ventricular hypertrophy because of the aortic stenosis. And in those patients, sometimes they respond less well to fluid. So we want to be keeping the CVP about 10 to 15, but if it goes to about 18, then that causes some diuresis as well. So it's a little bit precarious in terms of the CVP. But we need to keep a good CVP, but nothing like 8 or 6, I mean, that's not acceptable. We have to just fill and fill. And usually at about 60 to 80 mils per hour of just normal saline or normal SOM, sometimes you can even go to about 100 to 150 per hour. We'll be usually filling up patients to about about 1.5 to 2 liters a day, post-op day 0. Will be antibiotics, that will be for 2 days, usual broad spectrum, maybe a Rocephin, I haven't really decided on that. But, and as I say, they're usually a backup pacing, which will usually pace about 80 to 90 AAI, unless it's AV block. And I think that's a good thing. If we pace AAI, and if we see it's not going through, then that should be a sign to say, we should watch out for complete heart blocks. There might be some inotropes, because inside the cath lab, we might be using a little bit of inotrope to keep the pressure up. But over the course of the first day, day post-op day 0, we should be aiming to wean that off. So by next morning, post-op day 1, all the inotropes should be weaned off. And that should be supported by just fluids. We should be giving lots of fluids. We'll be checking astrop to see the pH balances. We'll be checking sodium and potassium, making sure the potassium's filled. Hemoglobin, if we need to transfuse, we'll transfuse. We'll be doing ECGs. checking the wounds. Of course, there's a bit of telemetry, and the patient will usually be propped up after 4 hours because the wound is secure. We don't need to lie the patient completely flat. Because what we want to do is we want to resume the patient as normal as possible, so by day 1, the patient should be sitting out in a chair, even in the intensive care unit. Okay, we'll be checking these bloods, ECGs, X-rays, and so on day 1. After the wound is checked in the morning after, the first day after the surgery, the wound's okay, the patient should be sitting out. And once the blood results are okay, and the urine output's good, the Foley and the arterial line comes out pretty much in the morning after. And so we should be aiming at the patient going into the general ward by the afternoon or post-op day 2. I know that they don't want to keep temporary pacing wires in the general medical unit, so we'll probably have to wean that off before we go out. So we should be looking at maybe post-op day 2 or 3. The temporary pacing wire should stay in no longer than 48 hours. So if it's a Monday we're doing, Tuesday the patient probably stays in intensive care at the IDU, and then Wednesday everything comes out and the patient gets out.
But you still can keep the wire there. You keep the box here in case you need it. So we can. You can keep the wire when you.
So remember last year that patient basically she got out on the day post-op day 1 evening. She was out post-op day 3, out of the hospital post-op day 3. So I guess we can keep the wire. She's doing great. We do echoes and so on. And by post-op day 2, we want the patient to be walking. So that post-op day 3, we can be thinking about discharging the patient. So that's about it, I think, for intensive care. Is there any questions you guys want to ask me?
So when you pace the ventricle at like 200, is that more like less like ventricle?
That's VT. I'm producing VT. Yeah. I'm producing pulse VT. And sometimes if the patient's ventricle is not great, we can actually induce VF. But we still do the balloon. So we do it under VF with balloon, and then we shock her back after the balloon. But all the pads will be there. A nurse will be standing by on the defibrillator. We go for the pacing, and then if it goes to 210, and you can already see it's becoming VF, nobody panics. We just do the balloon and say the balloon's down, and then you just shock. Everybody gets out, clear, shock, and then come back. Usually comes back. Usually comes back. And then usually we have to jump up and do a bit of CPR, but it usually comes back. But we'll have to go through that later with the cath lab nurse. It's okay. This patient is fine. This patient has an ICD, so it should be okay. Maybe turned off. Yeah, we turned off. But we have pads, so it's okay. It's fine. It's fine. But the EF is not great, so I'm not sure. We'll see. So, but I mean, that's the essence. But the patient has no open wounds. There's no sutures inside. So there is no need to keep the blood pressure low, as opposed to your open heart surgery, right? With open heart surgery, it would be nitrates, blood pressure low, so that you don't get bleeding. But with Tavi, there is no suture, there is no open wound, the blood pressure can be high. And we need to get the patient up and about very, very soon, because otherwise we defeat the purpose of Tavi. Is there any other question from the intensive care side? I mean, there's two parameters: CVP high, well not high, like well filled, and a map of good enough blood pressure. Because otherwise the urine output won't go. And you find these patients have the CVP will drop because if they're thick ventricle to start off with, the AS gets relief, and over like the next 2 days, if you do another echo, the thick ventricle goes away. You'll be all thin out. You'll be like a almost normal ventricle. So with that kind of space, you need to fill and fill and fill and fill. It's not uncommon to get 2 liters. But we push patients sometimes into heart failure. We'll just give them a bit of BiPAP or something. 得。
咁呢個聲即係咪可以 keep 好耐，或者係咪好似卡啲
哦，唔係嘅，因為啲聲可以so far我哋冇 data， 佢話 keep 到幾耐，我哋只可以話而家見到有啲人做咗8年至9年都 OK。 因為得8年。